Fantastic. All right, so we're back. We have a fantastic speaker today, and this is quite exciting. We have Dr. Katia Menacho Medina, who is a Peruvian cardiologist and a senior cardiac research fellow at the University College London, and also a consultant cardiologist with extensive experience in cardiac MRI, especially advanced cardiac MRI, and how to improve access to cardiac MRI in low-middle income countries. She started the Rapid CMR program, and she's going to talk about that a little bit today. So it's very excited to have Katia here, and I'm just going to hand the floor over to her. Go ahead, Katia. Thank you.
Thank you so much, Dana, for the nice introduction. Please let me know if you can hear me. And I will start with the presentation today. So we have 1 hour to discuss today about the application of the cardiac protocols, the rapid protocols in the assessment of cardiomyopathies. I'm very excited about this talk because I will, as part of this presentation, I will just do a brief outline about the rapid CMR protocol that I presented last week and some tips that we need to remember. The second part will be about discussing the new guidelines that we have by the ESC and how they reinforce the message of CMR for the assessment of cardiomyopathies. And finally, I would like to discuss with you 7 cases, and I can give you some tips about reporting, and you can get familiar with some cardiomyopathies and see how cardiac MRI can give us a good approach of those conditions. I would like just to disclose my acknowledgement to Circle CVI because I'm presenting these cases with this software today, and you can discuss with me about the clinical cases. So I think I presented this last week about the updated guidelines up to 2023 and the role of cardiac MRI. And compared with 2015, that was the previous update, we can see that cardiac MRI is increasing its role in the assessment of several pathologies in the field of cardiology. Specifically, in all the guidelines, we have 40 class recommendations type 1, 28 class 2A, and 19 class 2B. This is very important. And you can see from those diversity of pathologies, you can see that those which have the most number of recommendations are both groups, cardiomyopathies and perfusion. I know you already discussed about perfusion and cardiac MRI, so today we will focus on one of the most important ones, that is cardiomyopathies. And this is the message about improving the access of cardiac MRI with the rapid protocols. In our research that we finished in 2022, we managed to study 601 patients and complete those scans in 11 centers, 7 cities, and 5 countries. And the interesting of this is that all these countries were low-middle income countries, and you can see that just focusing on the essential of cardiac MRI, we managed to do a protocol that can be faster, easier, and cheaper. And you can see the overall timing of the scanning, as well as the impact of this scanning and the interpretation of these studies in the patient's diagnosis and management. So I discussed all this last week, but I want to reinforce about the use of essential sequences in cardiac MRI, where the most guidelines give recommendation and have a role not only in diagnosis, but only in follow-up patients and also in prognosis. And you can see is the assessment of function, where cardiac MRI is the gold standard to assess LV, left ventricle and right ventricle function, the assessment of tissue characterization, pre-contrast with the assessment of edema, diffuse fibrosis, or iron, for example. We can do a standard sequence, all sequences that are available in most scanners. And if you have access to mapping, you can also use those techniques. And finally, the post-contrast sequences, such as fibrosis, like gadolinium enhancements to assess fibrosis of the muscle. And this is the message about the rapid protocol. Some changes that we did to the standard protocol that is around 45 or 50 minutes. And I think one of the main tips that I can give you, and you also had from the previous talk, is try to do good localizers. There are some tips I gave last week, how to make it that faster and abbreviated to 2 to 3 minutes. Of course, this will improve when you are practicing more and have more experience on doing this kind of scannings. Do the longitudinal scenes. You can do the mapping if you have those techniques available, and or any other sequences for tissue characterization pre-contrast, and then you can continue doing your scenes, in this case short axis scenes, after the contrast administration. This will give you a time for the wash in of the contrast, the gadolinium, and then you can acquire properly your late gut pictures. Remember that this protocol is not for all cardiomyopathies. There are specific pathologies, as we will see in the examples, where we will need to change this. For example, if they are querying for any problem like arrhythmia in the right ventricle, or if they are querying about myocarditis, we need to do some additional sequence like assessment of edema with T2 stir for myocarditis, or mapping T1 and T2, or we need to do a special sequence of the right ventricle if we want to assess this pathology. So we need to be very clear which are the indications of using this rapid protocol. These are the results of the project that we did finishing in 2022 and was published in the European Heart Journal. You have the average time of the rapid scanning, post-contrast and non-contrast for the assessment of iron, 22 minutes and 12 minutes respectively, and also the impact on patients' management. After following this patient for 36 months, we found that there was a new diagnosis. Patients came with a suspicion of A pathology, but finished with a B pathology in 22% of patients, and also change in care, around 62%, that confirms what is already published in international registers, that cardiac MRI has an impact on patients' management in the specific group of cardiomyopathies. And this is also stated by the Society of Cardiomagnetic Resonance. You have here statements published last year, which are the indications where we can use these rapid protocols. And the one that we will discuss today is about the role of cardiac MRI in heart failure, if this cardiomyopathy is ischemic or non-ischemic. So that's a good use of these rapid protocols, as we will be discussing in the clinical cases. If you are also thinking in a source of arrhythmia, it's only essential doing the volumes and the gut pictures. If you want to assess ischemia, you can do a stress perfusion that can also be done as a rapid protocol. There are more studies and more publications that are trying to reinforce the use of a stress perfusion and doing in a scanning that can be less than 30 minutes, and also the assessment of viability. And finally, we can differentiate if this is a ischemic or non-ischemic injury with the use of late gadolinium enhancement. And I think this slide is very important that you can remember. So for late gadolinium enhancement, remember that it's really, really important because according to the pattern that we will find, having the good acquisition of the correct inversion time, you can differentiate if those are ischemic or non-ischemic. In the group of ischemics, you can have, for the assessment of viability and assessment of coronary artery disease, you can have subendocardial infarcts, and the extension will let you know if this myocardium is viable or not. Whereas in the group of non-ischemic, usually you can see there are different patterns of late gadolinium distribution, and each of them will make us suspect about a specific cardiomyopathy. Do this differentiation. Some of them can be mid-wall, for example, in dilated cardiomyopathy. Some of them can be patchy scarring, usually in the segment with maximum hypertrophy, like a primary hypertrophic cardiomyopathy. The big simulator that can have different patterns of distribution, for example, sarcoidosis. You can have subepicardial scarring, epicardial with epicardial distribution in different pathologies, including myocarditis, which is the most common, or also in other more uncommon conditions such as Anderson-Fabry disease or Chagas. And finally, there is a condition where you can have even a global endocardial enhancement, and that can be, for example, from endocardium to transmural distribution, like amyloidosis or autoimmune conditions, no? So remember, LEGAT has a unique contribution in cardiac magnetic resonance because it will make a difference in the clinical practice. That's why we need to make sure that we are acquiring good sequences and the interpretation can be correct using the correct inversion time. So this is about the new guidelines. I want to bring some slides about the use of the assessment of cardiomyopathies and the management of cardiomyopathies with the latest statement that was published end of this month and last month, sorry. And you can see here that the new guidelines is reinforcing about how important it is to have a correct phenotypic assessment of the cardiomyopathies, because with that we can have a better algorithm how to manage these patients and do a correct diagnosis. And remember that a cardiomyopathy is the definition of cardiomyopathy is a myocardial disorder where you can see that happens in the muscle of the heart, which has an structurally or functionally abnormality, but there is no any other condition like coronary artery disease, hypertension, valvular disease, or congenital heart disease that can explain that and that abnormality. And for that kind of cardiomyopathy, sorry about that, this one. So usually when we assess those patients, it will come because the patient is symptomatic or because they were doing a different study and they found that the heart was thickened and they was an incidental finding, or because the relative have a thickening in the heart, hypertrophic cardiomyopathy, and you have to do family screening. But the new recommendation of the guideline is that first, we need to do a morphological and functional characterization of the heart. And for that, ultrasound, echocardiogram, and cardiac MRI have an important role. Morphological traits can be, for example, if the ventricle has hypertrophy, left or right, if there is dilatation, left or right, and also if there is scarring on the heart, scarring in the myocardium, or any other characteristics by tissue characterization that is only assessed by cardiac magnetic resonance. So that's a plus. And for the functional traits, we have, for example, if there is systolic dysfunction, if it's global or regional, because it will make us think about a specific cardiomyopathy, and also if there is diastolic dysfunction, with a restrictive physiology. So very important to have this definition about the morphological and functional characterization. And after that, we can start doing with the additional tissue characterization that is provided by MRI, and we can classify the cardiomyopathies in different types following this phenotype of Lega distribution. And you can see here the most common groups that is divided now by the new guidelines is the hypertrophic cardiomyopathy, TCM. This is a new group that is advised by the European guidelines, that is the non-dilated left ventricular cardiomyopathy, the arrhythmogenic right ventricular cardiomyopathy, and the restricted cardiomyopathy. So these are the 5 groups. This is a new definition that the guidelines is giving for this group of pathologies, where there is a non-ischemic scarring or can be fatty replacement that can be assessed both by cardiac MRI. And it doesn't matter if there is a global or regional wall motion abnormality. And the other thing is that they can be only isolated global hypokinesia, but there is not also explanation of any scarring that can cause that. So this is a specific recommendation that the new guideline is asking us to consider for these difficult cases, and it's something that probably we will need to restart defining in the future and do more research about them. So, for example, this non-dilated left ventricular cardiomyopathy can be some dilated cardiomyopathies that they have the kind of mid-wall scarring, but they are not dilated, so they are not this dilated cardiomyopathy. Or, for example, those who have arrhythmogenic left ventricular cardiomyopathy, or they have both type of arrhythmogenic cardiomyopathy, but is more left dominant. And interesting is that you can see here that there are different genetic studies that and each of these genes can have a specific distribution of LEGAT. So just to briefly do a summary here, remember that going from the clinical scenario, going to the morphological and functional characterization that we discussed before, cardiac MRI or ultrasound, and then we can go to the phenotype with the 5 groups of cardiomyopathies that I discussed with you. And so this is the recommendation of the guidelines. So do a phenotype-based integrated etiological diagnosis using or following these steps. Remember the frequency of these conditions as well. They are not as frequent, but you can see that within these 5 groups of cardiomyopathies, HCM and probably DCM are the most common. You can see the prevalence in adults and also the prevalence in children. But we are talking about a low prevalence, but I have to reinforce here the influence that there are not many studies that assess how much or the real incidence and prevalence of these conditions in around the world, especially low middle income countries, and hopefully with the increase of cardiac MRI, we can contribute to discover more about the real prevalence of these pathologies. And you can see here the role of a multimodality imaging approach, and where we can use cardiac MRI and ultrasound, but specifically cardiac MRI is the only technique that will give you the tissue characterization. And there are additional tests that we need to do for specific pathologies, for example, bone scintigraphy for amyloidosis or PET-CT for myocardial inflammation. So those are additional imaging techniques that we need to use. But in general, for the first approach, definitely cardiac MRI is recommended. And you can see here how this has changed and updated in the guidelines. You can see here the cardiac MRI is recommended in patients with cardiomyopathy as an initial evaluation, which is really, really a big step for the approach and the incorporation of cardiac MRI in cardiomyopathies, and the class of recommendation is 1B. Even, and I highlight this recommendation 2BC because despite this is lower in the recommendation, I think this applies to all the countries, low middle income countries, because you, as my home country in Latin America, it's very difficult to access to a genetic study. Usually we need to send the samples to the USA or Europe for that. So even in those cases, just doing cardiac MRI may be considered in phenotype negative family members, where there is no, just to do a follow-up and early detection. If we start following these patients and we found the new appearance of an scarring or thickness, so that can make us more suspicious to have an early detection. And remember that there are specific characteristics for each cardiomyopathy, and also there is an additional role of using mapping techniques, and we can differentiate which pathology we are facing. For example, if we have hypertrophic in the 3 pathologies, so the heart has hypertrophy, but we have low T1, this is more Anderson-Fabry disease. If it's high T1, going to the one of the extreme high levels is amyloidosis. And if we have, for example, focal patchy areas of distribution, that is more for a sarcomeric hypertrophic cardiomyopathy. You can also see the pattern of distribution of late-acting amyloidosis, which is more diffuse, subendocardial to transmural distribution, and in Fabry, usually the scarring is in the ferolateral wall. So we can make the differentiation of the cardiomyopathies with the phenotypically with the support of cardiac MRI. In DCM, you have the sequence of T2 star to assess, for example, cardiac iron overload in patients with hemochromatosis, for example. If it's a subecardial scar post-myocarditis, if it's intralateral or epicardial leg gadolinium, this can be a dystrophinopathy, that is these uncommon sequences I mentioned before. Sarcoidosis is the great simulator. The scarring can be in the RV, in the left ventricle, can be subepicardial, endocardial, transmural. And finally, for example, if it's an apical transmural scarring, you can be thinking about Chagas. And these are the other groups, less common, but the non-dilated left ventricular cardiomyopathy, that the most common characteristic is a subepicardial ring scarring, circumferential, and there are specific variants of changes in the genes that can cause this specific pathology. Arrhythmogenic ventricular cardiomyopathy, that usually you can have the fatty infiltration in the myocardium or the distribution of the late gut in the right ventricle, or it can be subepicardial in the left ventricle. And finally, the restricted cardiomyopathy, that it has the apical obliteration, and we can have endomyocardial fibrosis as an example. We will try to discuss those cases now, some of these cases, and hopefully you can have a message about how important is cardiac MRI and starting recognizing the the patterns of distribution of the scarring with late gadolinium enhancement, and having an approach which cardiomyopathy we may be facing. So now I would like to discuss some clinical cases with you. I mentioned 7 cases. If Udana or any of the coordinators can let me know how is my timing, please, because I don't want to go after 1 hour. And,
oh no, you're still doing okay for time. Yeah,
let
doing
me
really
know
well
when
for
I'm
time.
let me know when I'm approaching maybe 15 or 20 minutes before the talk, ending the presentation. And what I would like now is I will give you the presentation of the case. So what I would like now with the participants, let me see if I have my chat box available. Yeah, I can see chat as well. I would like you to give me some comments about the cases. I also ask Udana and the team if they can allow to also put on a speaker if that is possible, but if no, we can discuss over the chat and you can give me some comments, okay?
No, they can. They can unmute themselves. They can.
Excellent.
Yeah.
So perfect. So that will be easier. So if I have if you want to contribute with the case or have any or can answer some of the questions I can give, that would be really great. Okay, so I will put the screen just like this right now because I'm sharing now the case. So briefly, so this patient comes from
so Katia, the answer is not in the slides, right? Just in the
no,
notes, right? It's not in the notes. Okay.
No,
Okay.
it's okay. So this is a case from Arequipa from the Rapid CMR project. So this is a patient who is 76-year-old lady. She comes from the highlands in Peru. So this is a city in Peru called Arequipa. You can see here. Is the nice volcano there you can see here called the Misty. So this lady they need to go usually to the capital city to have an assessment, but she was coming because of heart failure. She was in quite advanced, symptomatic, very symptomatic. She was class 3-9 and she was receiving medical therapy. She never had a cardiac MRI scan before. She was putting as the diagnosis of non-ischemic cardiomyopathy, but we didn't know exactly what was the cause of this. The problem is in the last month, the patient was having increasing of shortness of breath and it was more symptomatic. So we were doing this project and that was free for patients to have access to the cardiac MRI, and she came to the study. So sorry for this. I don't know Spanish. I will close this one. Yeah. And I'm sharing now my screen. Can you see my screen?
Yeah, we can see it.
Perfect. Okay. Great. So this is the case. So this is the scan as it is. Usually, as you can see, we start with the localizers. Okay. This was in a
so Katia, we're not seeing your slides. We're seeing the cake. We're still seeing the Peru mountains and the map.
Oh, really?
Yeah. So you just have to switch again.
Okay. 1 second.
No, take your time.
Okay, so if I stop sharing, but I share again now, can you see? Share screen. Oh, yeah, okay. Yeah. Can you see now the?
Yes, we can.
Yes,
Yeah.
it's clear now. We can see.
Excellent. So let me just, perfect. I just put this one, the chat box a little bit down and I can see it's here. Okay, perfect. So this is the localizer, as you can see, the first localizer. Usually, I think we did this in a Siemens scanner, Avanto, from 2010. So it's an old scanner, but has the essential sequences. Well, so in this localizer, the most important thing was to try to isocenter and put in the correct position for the heart. So see, this is the second localizer. And I don't have, I will put some comments now, but what I can see right now, because the localizer will also help you to assess the extracardiac anatomy, is that you can see a tortuous descending aorta, no? And you can also see, for example, here the aorta, the ascending aorta coming. Seems a little bit big, I will say, but of course we need to do the proper measurements. But that's what takes my attention. Remember that the lady, she is, I remember I mentioned 76 in the age, so she's an old lady. Okay, so those are the localizers, and then we go to the Hayes axial stack image as I discussed for the rapid protocol. So definitely the aorta seems be dilated. These are not the correct sequences to assess the aorta, but we can use them. There are specific guidelines to assess the aorta. You can do CNS sequences, you can do 3 angiograms, and we need to index to the BSA. But for this lady who has a small BSA, 35 seems borderline dilated. And anything that anyone who wants to comment, please let me know what do you think about the heart, because this study was to assess the heart. And you can see here the left ventricle, you can see the right ventricle, the right atrium, but there is something abnormal here. And you can see this big, I would say, dilatation of the heart. But this is what is taking my attention right now. These are still localizers that we need to plan for doing our CNS sequences. And here you can see the CNS. If anyone has a comment about the CNS sequences, please, I have here 2 slides.
Alex, you can unmute yourself if you want. Alex, go ahead and unmute yourself.
So this is the 2-chamber CNS, you can see here. And this is the 4-chamber CNS. Unfortunately, the patient was not contributing with the breathing, but and unfortunately, I think we had to do this scan very quick because the patient was really, really symptomatic. So we have to shorten some sequences, but you can see here the CNS sequences. Anyway, you can, if anyone want to put a comment or in the chat box, I will be checking. Here it is in the chat. Okay, let me see.
So Alex said it's not a contraction. It's not a contraction on the descending aorta. It's probably an artifact.
Yeah, absolutely. It's not a coarctation. You can see here it's not the sequence. It was not a study to assess the aorta, but you can see here some blood flow artifact here, but doesn't seem any obstruction here. And there may be other sequences that we should have done, but this study was not for that. But absolutely, we can do white blood sequences here or CNS to clarify that, no? But that was not for that. What do you think about the heart itself?
I think so. Kibet said it's apical aneurysm or something. Maybe apical aneurysm.
Yeah, perfect. That's actually a good answer. So you can see here that all the apex is totally dilated, is aneurysmatic, and the definition of aneurysm is when you have a thin wall and this wall is akinetic or dyskinetic. It's not contracting toward the same direction of the normal heart. So definitely we are talking about an apical aneurysm, which is really big in this patient. And the short axis as well, because with the short axis we will do a stack of all the ventricles, the right and the left ventricles. So we can see how is the contractions coming. A good contraction, you can see the basal wall seems contracting really well, and then we are going towards the apex, and then the mid wall, and this is the transition between the cardiac mid portion to the apex, and you can see how this is starting to be very thin. And is definitely, if you can see much better in these sequences, we can classify them as akinetic itself, and even some portions are going in the opposite direction that we will say is dyskinetic, and the wall is really, really thin. So it's very important to do these differentiations because there can be sometimes outpouches of the left ventricle in the apex that can be mislead with aneurysm. But for that, we can also do other sequences to clarify if that is the case. But definitely, this is a case of apical aneurysm. And then so far, if someone can give me which causes do you think can cause an apical aneurysm in this patient? Which conditions do you think that can cause this kind of aneurysm in the heart? And for that, probably it's important to show you the legat, because with that we can see how is the heart I have here another one, the fourth chamber. Yeah. Unfortunately, it didn't come well, but yeah, there it is. Anyone who can give me an answer about this? And also giving you the clue that the patient came from my country, Peru. But great. So here you can see the leg gadolinium pictures. And so we have two sequences in the leg in Siemens. We have the magnitude and the PSIR. So this is the magnitude in this side, and this is the PSIR on your what I'm pointing right now. Usually the PSIR will get rid of any kind of artifact, so you will be more focused to get, if there is a bad inversion time, we can appreciate this much better. But if we want to have a very clear leg gadolinium picture, both sequences should be very clear in seeing. So this is a good two chamber. And you can see here that so far doesn't seem any scarring in the walls of the ventricle, in the myocardium, but definitely you can see all the thin wall, and you can see like a white line coming here, so which is the aneurysm wall that is completely very thin, and there is enhancing of this area. And then we can also bring our short axis leg guard, and you can see here the whole short axis going through the base. So in the base, we need to see if there is any scarring of the heart going to the base, mid wall. And here is something that is happening. There is like a brightening of this wall between the mid and the apical, more mid, because you can see the papillary muscles, mid lateral wall. You can see some enhancement, more clear here. And this is not subendocardial, it's not subepicardial, seems more intramyocardial, in the middle of the heart. And here as well, you can see another scarring going to the anterior wall. It wasn't cut with these two chambers, that's why you can see it here, but it's going here. So definitely, and then you see the apex. As I mentioned, there is a very thin wall, but you can see the scarring in the wall of the aneurysm. So what do you think about this scar distribution? Do you think it's more ischemic or non-ischemic based on the slide that I shared with you earlier? Can you see my PowerPoint?
Yes, we can. We can still see it. We're looking at the circle.
Circle, okay.
Yeah.
Okay.
So I mean, I know, not that I know. I'm just trying to remember some of this stuff. Alex said it's Fabry's. Is it something to do with infectious disease? Some amount of infectious disease,
Fabry.
or
Okay, Fabry. Yeah. Thank you. Thank you
yeah,
for that,
Fabry.
Alex. So Fabry, actually, remember, of course, first we need to make the definition if it's ischemic or non-ischemic. All the scarring, and let me show this slide again, and then probably it will be easier to understand. What is this? Yeah, so this one, and we can make the differentiation. Yeah, you can. I'm sharing right now my PowerPoint again, and okay, share the screen. Yeah, can you see this slide?
Yeah.
So remember the ischemic one. Let me just take this out. Yeah, so the ischemic scarring usually go from subendocardium to transmural distribution. So because it follows the distribution of a coronary artery, which goes, the infarct goes from the subendocardial to the transmural distribution. And within the non-ischemic scarring, then we have different patterns. Which one is the patient's one? Ischemic, non-ischemic? Because I show you that the scarring was more intramyocardial, was not subendocardial or transmural, so it's more non-ischemic cardiomyopathy. Definitely. Alex mentioned about Fabry, but for Fabry, remember that usually the scarring it can be more usually transmural, and it's more, it can be in the usually basal inferolateral wall. Can be more intramyocardial, transmural, but in that specific basal inferolateral wall. And this disease doesn't give you an apical aneurysm as you saw in this patient. So coming back to our patient, so what happened is that this lady lives in the poor area. And in this area, there is a mosquito and that hosts one of the parasites that is called Trypanosoma cruzi. So this mosquito that is called usually chirimacha, this mosquito usually lives in areas where there is poor hygienic in water that is similar, for example, to dengue, and usually this goes and transmit this kind of parasite that is called the Trypanosoma cruzi in the human. And you can see the high prevalence of this condition in South America, and specifically in specific levels of altitude where the temperature is the most adequate for this mosquito to develop the vector, the triatomo vector. You can see that even without a proper assessment of the real prevalence, 16 to 80 million people are infected annually. And the mortality can be higher because can go like this patient takes years to go to that condition of apical aneurysm, and that can be a risk for sudden cardiac death, no? So this is usually what happened with this Trypanosoma cruzi infection. They go for an acute infection, acute phase, usually can be like a flu. At that stage, you can detect the parasite, usually lasts 8 to 12 weeks, but most of them will go to the chronic phase. At that stage, there will be a negative smear test, but PCR test can be positive. So the diagnosis is based in serological testing. And from here, some patients will go to the indeterminate form, so there is no sign or symptoms, and they will keep like this. But 20 or 30% of the whole patients will go to the determinate form, and from them they can develop the Chagas disease in the heart, Chagas cardiomyopathy. So unfortunately, 20 or 30% of these patients, if they didn't receive the treatment, that is the antiparasite medication at the beginning, they will go to this form because the parasite will go inside the heart and deposit there. And it's not only in the heart, it also causes gastrointestinal disease. You can see here megacolon, so it's a systemic disease. So as I mentioned before, so during the cycle of this parasite, they may go to an acute phase. Sometimes they can have like acute myocarditis that can be like a flu, and nobody will think about this. But when they go to the chronic phase, that is this group of patients, 20-30% of them will develop Chagas cardiomyopathy. And this is divided in different stages, but it will take up to 20 years for have this kind of condition that you saw in the patient that was the apical aneurysm. I would say that that size of an aneurysm that we saw in this patient usually is more thinking about Chagas, especially if these patients come from the endemic areas, no, like South America, or if there is a migration to other areas, because there are cases reported in the USA, in Europe, and Africa as well. So these are the most common characteristics of the Chagas cardiomyopathy: change in the rhythm, problems in the muscle of the heart, like a regional wall motion abnormalities, aneurysm, and if there is an aneurysm, there can be high risk of thrombus. This patient didn't have a clot, they didn't have a thrombus because you see the legat and there was not any black in the apex. And unfortunately, these clots can go to different parts of the body and do thromboembolism. So those are some of the complications. And for Chagas cardiomyopathy and cardiac MRI, remember that they can start with very small apical aneurysm, like a finger type small apical aneurysm, but they can go to the big ones, like the one that we saw. That is the aneurysm, the big aneurysm in the apex. And usually the scarring goes mid apical inferolateral, as you saw in the case of the patient that I showed you today. It was this kind of scarring in the mid intramyocardial lateral wall, and also in the apex, which is very characteristic of Chagas cardiomyopathy. The theory why this is go usually in the lateral wall is because usually in these areas there is like a more weakened vessels, blood vessels, and that can increase the risk of scarring in this area. Usually, even if we have like an early stage when the patient is not in the advanced disease, if we do stir sequences to assess edema, you can see some increase of the signal here, and even it can be the possibility to detect this stage very early and avoid to have the evolution as you saw in this patient. And finally, remember that the fact that the patient have an aneurysm and have a scarring in the heart, that can be a prognostic value for patients to have a worse mortality. So the presence of late was in difficulty associated with more primary and secondary events, cardiac events. So, and this LAGAT can also be a predictor if the patient will develop ventricular tachycardia and then have a death. Okay, so any question regarding Chagas cardiomyopathy? Any one of you thought about Chagas? Yeah,
Yeah. Yeah, Alex thought it was more diffuse, but now he's seen.
Yeah.
He thought it was more diffuse, but now he's seen that it could be non-ischemic and focal.
Yeah, so definitely it's a non-ischemic scar because it was intramyocardial for sure. And as Alex mentioned, no, Chagas diffuse in the whole myocardium, no, usually it's more in the apex, Alex, as you saw. And if you find the scarring, usually will be in the mid intramyocardial in the lateral wall, as you saw in the examples. Perfect, so that's the first case. Let me know, because if we go fast, we can.
Oh no, you still have you still have 15 minutes, and there. I mean,
Yeah,
we're
let me
doing
know.
okay. We're doing okay.
Okay.
Yeah, go ahead. Yeah.
Well, let's go to the second case. So it's a 56-year-old gentleman. He has high blood pressure, shortness of breath on exertion, and family history of ischemic heart disease. So yeah, the fact that he has hypertension, but there is also family history of ischemic heart disease. And the electrocardiogram showed there was abnormalities in the electrocardiogram. There was T-wave inversions in the anterior leads, and there was Q-wave in the inferior leads. So very abnormal ECG in a person who is 56-year-old, symptomatic with shortness of breath, but also strong family history of ischemic heart disease, coronary artery disease. So they want to see if this is also ischemia, if there is a infarct, or it can be because of the hypertrophy of the heart, it can be primary hypertrophic cardiomyopathy. So I will go to the case number 1. Okay, so this is the case number 1. So this scan was done in the UK. So this is an example from my hospital. And I will stop sharing now because I think you don't see my yeah. I hope you can see my screen now.
Yeah.
Perfect.
Yeah.
So perfect. This is a scan in Siemens 1.5 AERA. You can see that in this scan we use AI technology, so you can see that even it gives you the ECG data. So patient was in a heart rate of 67. We do the same as we did with the other scan. We do the localizers, one first localizer, and then we do isocenter. You can see the aorta, and we go to the isocenter localizer. So now we are note that the heart is in the middle. And what takes your attention in general about this localizer? Anyone can speak or put a comment in the chat. What do you think about the muscle of the heart itself? Do you think it's a normal muscle of the heart, maybe thicken, not thicken? What do you think?
Very thicken.
Thicken,
Thick,
yeah,
yeah.
seems that, yeah, absolutely agree. This is the axial axial localizer. We have the haze, that is the black blood, and we have the white blood. Usually, if the patient has hypertension, we also see aortopathy related, so problems in the aorta. This aorta, usually Caucasian patients also, we have higher BSA, so doesn't seem dilated, the aorta itself, not like the other lady that we saw before. But you can see here also that the heart seems thickened, as you mentioned. The muscle of the left ventricle seems very thickened. And so we did our localizer to chamber and short axis, and then we are going to the short axis, the cine sequences. So I will start with the 4-chamber. I have here the 3-chamber, and I have here the 2-chamber. Okay, can you see that? Sorry. Can you see? And I will start playing them. Okay, any comment about this heart? What do you think? So definitely, as you mentioned, it's a thickened heart. Do you think there is a specific wall in the heart that is very thickened, or is all the walls of the heart are thickened? What do you think? And which part do you think is more thickened? For example, let's say the basal part, the mid part, or the apical part? Anyone who wants to put a comment on the chat? Or Udana, what do you think? What do you think about
I mean,
this?
yeah, it looks like it keeps changing, but sometimes it looks like the lateral wall is thicker. Sometimes it looks like
Yeah.
it's not, because I guess because of the slices are changing. Yeah, but I could see
Okay.
that one is thicker than the other one.
Yeah. And the other thing, I will put a comment here if you can see the pictures moving.
There's a valve. Is the valve missing on one of them, or is that just the way the slice was acquired?
Is the way we usually acquire. We usually acquire these pictures in 4-chamber, in 2-chamber, and
Yeah.
3-chamber. That's how we usually do. That's the standard sequence. But what I will see here, if I stop the pictures, you can see here that the apex, this is the apex, the apical part, is, I will say, is obliterating. So is usually the apex, as you see, well, the other case was an aneurysm, but the apex shouldn't have this kind of obliteration. If I measure this obliteration here, you can see the number I'm putting here is around 22, which is abnormal. Usually the obliteration of the apex of the heart should be less than 1 centimeter, but he is abnormal, it's 2 centimeters. That's one thing. So that is something for me that is abnormal, because even if it's just hypertension, I can have some degree of hypertrophy, but I shouldn't go to this degree of cavity obliteration that you can see here, that is more than 2 centimeters. The other thing as well, I will just put the 4-chamber, and you can see this one. Hopefully you can see bigger. Usually, if we see the normal heart, usually the basal, the mid part usually are more thick, and the apex usually go more thin. But here you can see that you are losing that kind of apical sparing. So if I measure here, let's say, is 11. It just, this is not the best measurement, of course. So
It's crude, very
an
crude.
example. This is 12, and here you can see is coming to almost 15. So this is abnormal. So the apex shouldn't be thicker than the base or the mid wall. So that also shouldn't be, because if it's hypertensive cardiomyopathy, you will have a thick heart, but usually will respect that normal pattern of thickness from the base to the apex. So we are losing the apical sparing, and we are also having abnormal apical cavity obliteration. Okay. So then this scanner has the possibility to do T1 mapping. You can see that the T1 mapping here, usually in our scanner, is between 1,960 to 950 to 1,060 as normal. So here I have 1,046, which is normal. But if I go to the apex, sorry about that, the T1 mapping is going up to 1,110. So that's abnormal. So this is telling me that there is high T1 in this area also of thickened heart, okay? So T1 is high. Remember that this patient has history of ischemic, strong family history of ischemic heart disease. So there was family history of coronary artery disease, so they asked us to do a perfusion. I know this is not the scope of my presentation today, but I want to show you what came the perfusion. I need to show this one actually. Yeah. Okay, so you can see this is the perfusion. This is a perfusion mapping. It's an additional sequence we have in our hospital. But you can see that usually if there is a problem in the arteries of the heart, usually it shouldn't be a problem. Should be nice and beautiful, as you can see here, no, yellow. But what happened here in the area of the apex that I told you that was a thickened heart, you can see that there is a problem with the blood supply. There is a problem of the blood circulation, which is also abnormal. It's not a problem of the coronary artery disease. It's a problem of the small vessels of the heart in the apex. We call that microvascular disease. And this is affecting the area that was abnormal in the pictures, that was the apex, okay? So that's very clear in the stress perfusion. And finally, I will show you the legat, because that's, the short axis in as well, and you can see. Let me show you the short axis in. So the short axis in is here. Hopefully it comes as the whole stack. If it takes too long to upload, I will need to do, yeah, there it is. So I'm playing all the pictures. So this is the whole short axis stack. So slowly, sorry about that, but you can see that even in the apex, you don't see the blood cavity, so it disappears because the wall is so thickened that is obliterated all the apical wall. And this is the best sequence to measure the thickness of the heart. I said 50 millimeters, but that's abnormal. Anything that is above 11 millimeters in the thickness of the heart, that's abnormal. So it should be more than 11. And one can start suspecting of hypertrophic cardiomyopathy, primary hypertrophic cardiomyopathy, when it's more than 15 millimeters. And finally, I have here, this is what the AI, we have artificial intelligence in this scanner, is giving us that the maximum wall thickness is 18 millimeters. So that's what is measuring the machine. You can see here, this is the area of the maximum thickness. So it's more thickened in the apex of the heart, and the maximum thickness is 18 millimeters, but there is also thickness in the septal wall. But definitely is more abnormal in this area. Okay, so that's completely abnormal. And finally, I will show you the legat, because that's what we need to see as well. Sorry. So
Katia, while you're doing that, these are protocols that are, I mean, like if the images look very, very good for, I don't know, rapid and fast imaging. But you mentioned AI.
This is not rapid at all.
Oh, this is not rapid. Okay, that's what I was gonna say.
This is not a rapid protocol. This has additional, but I'm bringing here because it's very helpful for us to see the pictures. But to be honest, to assess the diagnosis of this condition, of course, you have additional nice mapping pictures. But to make the diagnosis of this condition, you just need to assess the thickness of the heart and also the legat. That's what we are doing with the volumes and the legat. And this is the well, let's see if we can have one later one. Yeah, it's difficult to see, but you can see here in two chamber there is something here. Can you see here?
Yeah.
What do you think? Is this the same, subendocardial, epicardial, or intramyocardial? Or is in the middle? Is ischemic or non-ischemic? That's my question. Anyone? Ischemic or non-ischemic?
I'm a brain person, man.
So also here you can see.
I haven't seen so much heart in a long time. It looks like it's inside the wall of the like in between the wall of the myocardium.
Exactly. Seems more
I think it's a ischemic. Yeah, I want to say it's ischemic, but I'm not sure.
It should be non-ischemic. If it's in the middle of the heart, non-ischemic. And you can see also here. Yeah. Perfect. So we have all. Anyone who wants to give a comment about this?
Oh, they all got it right. They all said non-ischemic.
Hey, that's really good. Excellent.
Yeah.
So yeah, and anyone would like to tell me what is this? Sorry, anyone think what maybe? Do you think it's hypertensive heart disease because he has history of hypertension, or do you think it's more a cardiomyopathy, a primary cardiomyopathy?
I think you took it down, so we might have to look at it again. But somebody said, Alex said it looks like non-ischemic, but in the right coronary territory, and has some issues.
Yeah, if it's non-ischemic, so you cannot say coronary artery territory, because when it's coronary artery territory distribution, that is ischemic. And the right coronary artery usually is in the inferior wall. So it shouldn't be that. So this is what this patient has. Can you see my screen now?
Mm-hmm.
So we are talking about a patient who has apical hypertrophic cardiomyopathy. Of course, I show you a nice scan with all the mapping sequences that is in my hospital, but we can do a fast protocol, make it shorter, and do just the CNS sequences and the legat, and we'll have the same conclusion. And if you have the mapping, excellent, because remember the mapping was high in this area, so was telling us that there was possibly scarring in the heart that we found in the legat. Remember that when we see apical HOCM, very important you do a correct planning of the CNS sequences. For example, here it was going very angled. So to do a correct two-chamber and have a good assessment of the apex, you need to do a proper cutting of the heart, more anterior and inferior wall. Otherwise, you will have bad pictures. And it's very important for this kind of disease to assess the proper apex. So that's why it's important to do a correct planning. And for all the radiographers that are familiar with this kind of problem, what's the problem here? What is coming here? Anyone who want to tell me? So we detect this problem because it was limiting the image quality of the apex, and then we improve this and we make it more nicer. What do you think was the problem here? Anyone? What do you think was the problem?
Hypertension. Someone said HCM, hypertensive, heart fallover, some.
Yeah, the person who say HCM, yeah, that's the condition. HCM is a primary hypertrophic cardiomyopathy. That's the disease. And can someone please tell me how to improve this sequence? What the radiographer did in this scanner to get rid of this? What was the problem for the radiographers? So the problem was that the field of view was very small. So if you increase your field of view, you will avoid this wrapping. Exactly, and you will have a better picture. So very important for apical hypertrophic cardiomyopathy to have a correct field of view, because you want to see the apex. If you cut the apex, then the clinician will start complaining. So very important to have a correct field of view. So this is a primary hypertrophic cardiomyopathy. In this case, there are several variants. There are some that goes in the base of the heart, in the mid wall, in the septum, but this one is specifically in the apex. And there are three forms of these ones. The one that we are assessing today is the pure one. Sorry, the mixed one, because there were also thickness of the septal wall, more basal wall. So but there are some of them that are very pure. And remember that the usual definition to say that this is hypertrophy is more than 15 millimeters. But in the apex, that is not the reality. And there are some people that even are recommending to do a more index assessment of the thickness of the heart to define if this is hypertrophy or not. But this is something that is going with more studies. But at the moment, anything that is more than 50 millimeters of thickness, it will make you think that this is hypertrophic cardiomyopathy. And sometimes even there are the thickness of the heart is no more than 50 millimeters, but you can see even the scarring of the heart, as you can see in this example. And this is also a criteria that is telling you that this is more apical hypertrophic cardiomyopathy. And even some changes in the heart, for example, if there is dilatation of the atria of the heart or problem in the longitudinal function, you can also think this is related with apical hypertrophic cardiomyopathy. This is the example I told you, remember? Usually, if you have a normal heart, should be the opposite, should be more thickened in the basal wall and thin in the apex. But here you can see the change of that pattern. So the apical sparing is changed. And even this wall is no more than 50 millimeters, but it's making you think that this is an early stage of apical HOCM, and this patient needs to be followed up. And these are more clear examples of advanced apical HOCM. Even in some patients, they can do to apical aneurysm, very small apical aneurysm, as you can see here, and also a lot of scarring in the apical walls. So that's all regarding apical HOCM. Any question? So this is a primary hypertrophic cardiomyopathy, and in this case, is involving the apex of the heart. Okay, any question about this case? So again, we are going to a non-ischemic cardiomyopathy, but in this case, it's a primary cardiomyopathy, and it's called apical hypertrophic cardiomyopathy. Usually this is a hereditary condition, so definitely the relatives of this patient needs to be screened, and also they need to have a genetic test as well, and they need to have follow-up because those patients can have a arrhythmia because of the scarring of the heart, and they can have sudden cardiac death. So it's very important to follow these patients as well. Okay, so I will go, sorry, I should have not stopped here, share the screen. I will go for another case.
Okay. So it's you're now at the hour. Everybody's still hanging around. We can go ahead.
Yeah.
People that want to leave can leave, and then maybe after this case we can wrap it up. It's fantastic.
Yeah.
I think they're all learning a lot. So let's go ahead.
Perfect.
Yeah.
Let's do this case and then we finish. Okay, I promise.
Yeah.
So this case is a let me see which one I give you, and they can be more interesting. I will give you the case number 8 because it's something that probably you didn't see. So case number 7. 1 second. Okay. Yeah, this is another patient from Peru. This lady, she's a 69-year-old lady. She complained about shortness of breath and fatigue. Remember the diagnosis I just gave you before, apical hypertrophic cardiomyopathy. So they gave this diagnosis to this lady. But the doctor wasn't so clear about this because he found something very, very strange in the ultrasound, in the echocardiogram. So they asked, please, can you do a cardiac MRI to this patient for the rapid protocol? And this lady also came from Arequipa, the same city as the first patient. She had very poor economical resources, and we implement the rapid protocol in this city. And so she had the scan, and this is what we found. So, sorry, did you see my screen? No. Yes?
No, not yet. We're looking at the case. Yeah, I haven't seen the
case,
images yet.
only the case. Yeah. Okay, perfect. So, can you see now?
Yes.
Yeah, stop sharing, sorry. Okay, it's going now. Okay, so this is the case. Okay. Sorry, I think I should have here the case number 8, but it's not here. Apologies about that, everyone. I think I will need to do another case, unfortunately, but let me choose another one quickly. Okay. So this is the case. This is something very common in Asia as well, and also parts of Africa. This is, I will just read the case to you. It's a 46-year-old patient. He has history of beta thalassemia. This is a blood condition, hereditary condition that is a hemoglobinopathy. So, and this patient was transfusion dependent, and he had iron deposition in the heart and the liver, and they want to do a follow-up because the patient was receiving treatment for that. And this is the case. Can you see my screen?
Yeah.
The CBI.
No, not yet. No, not yet. Not yet. We're looking at you.
Okay, so. Oh, come on. Share screen. Okay.
Yeah.
So this is the last case. Okay, so this patient has beta thalassemia, and this is a hereditary condition and hemoglobinopathy condition where the patient unfortunately has a change in the shape of the red blood cells, and they go to constant hemolysis, destruction of the red blood cells, and these patients usually have to go transfusions because they are in constant anemia. And these transfusions will put them at risk to have iron in the heart and in the liver, and in different parts of the body itself. So that's why they need to do these MRI scans to assess if there is any, the severity of the loading of iron in the heart and in the liver. What do you think about this picture? So this is the first localizer. What do you think? Anyone who want to comment about this? This is not cardiac, but you can see it's a big, probably kidney cyst.
It's in the kidney as a cyst or something.
Yeah, probably. But it's in the left kidney. But what do you think about the liver? What do you think about itself, the liver? So usually the liver shouldn't be so dark. And if you can see here, the liver is completely dark and it's even the same as the lung. So that's not a good sign, because it's telling us that probably there is iron in the liver. And even if we go to see the heart, you can see even the heart shouldn't see so dark like this. So that's another clue that is telling us that is also probably iron deposition in the heart. But we will see this with the specific sequences, what is happening here. So after that of the localizer, we are doing this sequence. So you can see here the axial white blood stack. What is this? What is happening here? There are some masses, that is coming like this heterogeneous tissue that is coming behind the sternum. What do you think is that? And also here, it's coming here. You can see there are some abnormal mass that are tissues that are coming in the paravertebral. What do you think is this? In a patient who has constant hemolysis and any comment?
Somebody said thymus.
Yeah, agree with the thymus, yeah. Perfect. And what about these ones? Exactly, extramedullary hematopoiesis. Exactly, because there is so much hemolysis that the body is trying to find different sources of hematopoiesis, and in this case, it's doing extravertebral extramedullary paravertebral hematopoiesis, as you can see here. No, so these are a response of the body that is trying to get different sources to create hemoglobin. So well done with the response. And so now we are going to the CNS sequences. The other thing of these patients, always checking if there is a spleen, because when they are young, because of the hemolysis, usually they go to splenomegaly, because the red cells goes and is processed in the spleen, so they usually go to splenectomy. So it's very important to assess if this patient have a spleen or don't have a spleen. I don't think the patient has a spleen here, actually. Probably they remove when he was there. Okay, so now we are the same. You can see how dark is the heart, the muscle of the heart. So that's also a sign that is telling us that there may be iron deposition in the heart. And you can see here the sequences, the CNS sequences. So definitely you can see very dark liver, and also very dark, the muscle of the heart is very dark as well. Sorry. And what do you think about the contraction of the heart? Is working well? Is contracting well? Seems is doing well. Of course, we will need to do the proper assessment of the function of the heart, but seems that it's doing well. But definitely the most concerning is how there is the dark signal in the heart and in the liver. And for that, we have a specific sequence to assess if there is iron in the heart. One of them, if the scanner has a sequence that is called mapping sequence, usually this will become blue. This is the condition that will make the T1 very low. In our scanning, usually the normal value for this scan was between 960 plus minus 60. You can see how low is this. So iron is one of these conditions that will make your T1 very low. But more than the T1 mapping sequence, the one that will allow us to see if there is iron in the heart is called the T2 star. For that, this can be free softwares to do that. You don't need to have this sequence here, and there are free software where you can analyze T2 star in the liver or the heart. And I will bring here the liver. It's a 12 echo gradient echo sequencer, and then we do the drawing, trying to avoid the vessel of the heart, and you can see how much is the iron. Anything that is less than 2 milliseconds is severe iron. So 1.84 of T2 star is very, very low. And that is telling us that this is severe liver iron, and the same for the heart. Another sequence, T2 star sequence, T2 gradient echo, and you can see here that the value of the the value here of the heart, muscle of the heart is 3.2. Anything that is below 20 milliseconds is iron deposition in the heart. And if it's less than 10, that is severe iron. So this patient has severe liver and severe cardiac iron overload, okay? So that's the case I want to present. And briefly, I just want to tell you about this condition, and then with that, I will finish. So this is the condition that I mentioned. You can see my screen. So those are the patients, sorry.
Yep.
Those, I just put a full screen mode. Those are the patients that I was mentioning. Those are the patients with beta thalassemia. So this is a hemoglobinopathy. It's a systemic disease because there is also problems with the development of the bones, fractures, development in the delay in the puberty, and also problems in the pituitary gland because the iron also deposits here. Problems in the skin, and these patients usually go to splenomegaly, as I mentioned before, and they are very dependent to the transfusion. And the major cause of death in these patients is the problems in the heart because of the iron deposition. That's what I show you today. You can see how dark is the liver and also the heart, that make us think that is deposition, and also the extramedullary hematopoiesis, like we saw in the case. It can be also in the ribs, or it can be back in the sternum. And the condition about iron cardiomyopathy, CMR is the gold standard to assess this condition with the T2-star sequence, as you can see here. And remember that there is not if I have liver, then I will have heart deposition. It's not like this. You can have normal all liver and normal heart, or the opposite, all heart and no liver deposition. And the lowest the T2-star curve that goes, it will tell you that there are more risk of iron overloading. And if the T2-star goes below 6 milliseconds, like we saw in this patient, there will be a 20% increase of annual risk of heart failure. So that's why it's important to assess the T2-star and monitor these patients. Because if these patients who have iron overload, they need to go to chelation therapy. That's the only therapy that will take the iron from the inside the heart and also from the liver. And if we follow these patients and give the correct treatment, you can see that they can improve. As you can see in this case, the iron is getting rid in time, but usually takes a lot of time, even more years, because the position is inside the cell of the heart. And this was implemented in the UK because the mortality of this patient was very high before the early 2000s because of the complications in the heart. But once we implemented cardiac MRI, you can see there was a drop of the mortality because of the use of cardiac MRI. So cardiac MRI not only helps you with the diagnosis, but also helps you with the follow-up of patients, see if they are responding to the treatment, and also to prognosis. Hopefully this can be implemented also in Asia, in other developing countries, because that will also have an impact on patient care. That was one of the projects we were doing in India. That's all. Any question that you have?
This is fantastic. It's a lot, but it was good. I did learn a lot. So yeah, so we'll probably take a couple questions, and then we can all take a break. They had a session before you. So any burning questions for Katia? You can either type it in chat.
One of the participants told about insufficient contraction. So actually, it could have been my function impairment. I should have need to do the proper quantification of the function of the heart. But you are right. Probably we will borderline this function of the heart. So I could have maybe checked the short axis CNS and do that. But for that, the doctors will have a post-processing analysis to assess the correct function of the heart. And this protocol is non-contrast. So it's only done in 10-12 minutes. So that's the benefit, and you can change patient treatment and follow them up with the correct using of this technique. So it's very, very helpful.
Very interesting. Yeah. Any questions? Anybody questions? I think there's a lot of processing, a lot of information, but it was good information. Yeah. Katia, this is fantastic. Thank you so much. Oh, only a great. Oh, so yeah. So yes, thank you. That I think that's what Alex is saying. Yeah, so Katia, thank you so much. You have, obviously, you're very well knowledgeable about this, and I guess we will connect later on to actually get the rapid protocol and figure out when are the best cases to use it and when and where we could actually start to implement this, at least in some places where we are training.
Absolutely.
Yeah.
Absolutely. Yeah. It was a great pleasure to help. If you have any question about the rapid protocols, you have my email. You can contact me. I'm very happy to support in any way we can implement this as well in other countries.
Yeah. Thank you so much, Katia. Enjoy the rest of the evening, and thank you, everybody.
And sorry about 50 minutes late. Thank you.
Oh,
Bye-bye.
no, that's fantastic. That's fantastic. Thank you. Okay.
Bye.
Bye.
Bye.